All right, sound check. Worcester A-OK? One more round here of neuro, and as I said, the last thing we have to run through is the spinal cord here. And this shifts gear a little bit from obviously CSF and production, et cetera. But it really just connects the dots and gets us back into that whole wiring mechanism of cortex, brainstem, cerebellum, and now just a continuation into the spinal cord. With the spinal cord, traditionally, we're looking at it functionally, and which means if something dings it, you need to know what function is lost. There'll be three, we're going to go over, maybe, I can't count, but, say 7 or 8 tracks, and we will name them individually. But there's only really the 3 big ones that I will identify that you really need to be able to follow the pathway, know when it crosses, know where it goes, and be able to say, if I lose half the cord at T6, I know what the damage would be, for those 3 tracks. So the other tracks, and I'll try to point out which ones, you don't have to be quite as concerned about the actual pathway, but more the function of the tract. So with that said, again, I think we've did this in anatomy a little bit, but the cord itself, as we know, ends at the TL junction. So go back, just review the terminology. The dentate or denticulate ligaments were that outcropping of pia, evagination, if you will, that really connects the pia to the arachnoid dura on the outside to anchor that cord, so it's not just floating around in there in CSF. It also has some physical anchoring, if you will. Central canal, as we said, we talked about it, a continuation down that 4th ventricle, down the spinal cord, but it's questionable really how far it goes down past the C-spine, really, even though every single slice of spinal cord, you see the little dot in the middle saying central canal. And also, terminology, conus medullaris, just simply the end of it. Phylum terminale, again, kind of the last bottom line anchoring of the pia and the cord from that TL junction all the way down to the end of the dural sac in the sacral area. Okay, so again, you can review through each of those. I think that is literally cut and pasted from the anatomy slides. This is a nice visual, though, to appreciate. As I said, here's our subarachnoid space in here, and as I talked before, you eventually have to get through to a transition out into the outside world of these nerve roots. And so again, we talked, as I said, this transition, similar to that invagination up in the CNS of the brain where the arteries are penetrating, is a juncture where this CS fluid can be hooking up with the arterial and blood supply and lymphatic supply, around this dural sheath. So that's what we're referring to as at each segment, the potential for CSF reabsorption. Okay, we'll also discuss the enlargements. I don't think there is too much to chat about other than obviously the plexuses, the cervical plexuses, the lumbosacral plexuses. Since there's a lot of nerve roots, the cord itself is a little bit thicker. In the thoracic region, just a nerve root tends to be a little bit thinner, and that's about the gist of it. Each of the nerve roots, again, this is probably Anatomy 101 from sophomore year of high school, but you should be able to identify the individual portions of a of a spinal nerve root. There's a dorsal nerve root and a ventral nerve root. So essentially, a spinal segment or a spinal nerve is really just a conduit of a bazillion axons either going in or going out, and those axons eventually split and find its way into different nerves, musculocutaneous nerve, median nerve, blah blah blah. But all of the area that those nerves are plugging into from a sensory standpoint also have to get back, and so those thousands of axons are also part of this wrapped sheath conduit that are making their way back. But eventually, all the afferent returning sensory information splits out of this common conduit and that's what makes up the dorsal nerve root. Also with those sensory nerves, the cell body is located, at this enlargement known as the dorsal root ganglia, if you will. And again, when you're bathing an epidural, this is, where you're putting that anesthesia to bathe these nerve roots, if you will, to, create the desired effect. So that's a dorsal nerve root, lands in the back, lands into the gray matter, and eventually interconnects with the front end of things on the anterior horn and makes the ventral nerve root. Ventral nerve root, all efferent, exit, outgoing, output, so some kind of either skeletal muscle motor output or some kind of autonomic motor output, if you will. So that's the ventral nerve root. Individually, again, I think in your patient assessment, I think you've probably looked at DTRs. Have you looked at myotomes kind of as a screen I'm kind of looking at blank looks. I'm not sure if it's Friday morning blank or true blank looks. But each spinal segment supplies a specific region of the skin. And it's not based on peripheral nerve. It's just based on the majority of the axons coming out at, say, C6, come along this region of the arm or the hand. And so if there's a sensory loss in this region, then that would be consistent with, we got a problem at C6. Versus if there's just sensory loss along the median distribution, I got a problem with the median nerve. So there's a little different patterns sensory-wise that help you out, in your clinical exam. Same thing motor-wise. C5, elbow flexion, myotomes, a majority of those axons exiting out of C5, or I should back up, a majority of the axons that plug into, say, the biceps originate in C5. Some come from above, some come from below, but a majority of them do. So again, if you got a ding at C5, then you've got loss of that myotome strength versus musculocutaneous would be strictly, coracoid or biceps and brachialis and so on and so forth. So again, dermatome, myotome, and then last but not least, the reflexes all relate to individual spinal segments. The deep tendon reflexes only pertain to a handful of segments that form this root. In other words, your patella reflex, those axons are making their way back to, and again, it depends on your patient assessment text. Some people say L3, L4, some people say L4, but essentially a majority of those are going back into the L4 segment. But meanwhile, they make their loop. The axons coming out of 4 also go back and plug into the quad. So when you give it a quick stretch, that loop goes around. It gives you your deep tendon reflex. So that's orientation, I guess, clinically as far as segmental nerve roots and pathological damage there. When it comes to nerve roots, the real discussion is what I kind of alluded to earlier, is clinically your exam is trying to figure out, is it an L5, it is a C5 problem, or is it a median nerve problem, a sciatic problem, anterior tip, whatever the case is as far as the peripheral nerve goes. Things that can wreak havoc, anything that is going to quote-unquote squish it, but it's usually stretching it that causes the problems. Nerves far more susceptible to tension than they are squishing. Not that if you squish it, it's going to work, but they've got a little bit of a tolerance for getting compressed. But if something is pushing it and making it stretch a little bit, then you're having nerve dysfunction and signs and symptoms of a nerve root radiculopathy or something like that. So any of these things, whether it's bone spurs, tumor, disc, et cetera, can create the same outcome. All right, on to blood supply. Spinal cord, tissue like everything else. Easy to wrap your head around the concept of a stroke for CNS, concept of myocardial infarct for your heart, but your spinal cord can stroke out, if you will, for lack of a better word. Usually it gets damaged out, spinal cord injury and the damage that's associated with it physically. Sometimes not ideal, but it can be resolved post-surgically. There's a lot of science and technology to maintaining blood flow, cooling down that cord. You've got a window of time, things that can go on to make sure that, when spinal surgery is going on, they can ramp back up and, restore healthy blood flow. So things can go wrong that way. Anything from, the Harrington rod surgery and things like that, where somehow an infarct, unfortunately may occur. But the blood supply to the spinal cord, as far as pathways, the first message is we're going to look at the front and the back, but there's some inconsistencies. In other words, there's an impression that you'll have one artery that runs down the length of this and, supplies here. But it's a little more, patchwork along the way. In other words, you have a supply here, supply here, supply here, discontinuation here. So again, the artist renditions give you this impression there's a single hose running up and down. To some degree that's true, but there's little variations in between. So we'll start with the anterior spinal artery. First take-home message is there's one artery, if you will, given the limitations, what I just said, that runs down the front of the cord. And the real key is this artery sends off plenty of branches that, for no surprise, are going to supply the front side of the cord. And essentially, it supplies the front 2/3. In other words, I think I've got this highlighted. Eventually, I do. But essentially, it's supplying this whole region outlined there of the cord at each level. So here's that anterior spinal artery coming down. It gets back up and help and supply from different segmental arteries all the way down the spinal cord, if you will, to continue this thing called the anterior spinal artery. As I said, eventually, this is the one I think I was looking for. There we go. So when you look at this anterior spinal artery, again, you've got the supply all in the front here, first 2/3. Meanwhile, on the back side, we're going to do the posterior spinal artery, and there's two of them, one on each side. But essentially, they just take care of that quote-unquote posterior column of the spinal cord. So leading ahead a little bit, if you kind of, what I was alluding to earlier is you should be able to recognize, obviously, if there's damage through trauma or if there's some kind of infarct and what the net result would be. In other words, functionally, if you know what's going up and what's going down through the different regions of this spinal cord, you know what would be affected. So you would know what pain, expected pain loss or expected motor loss would be, or mechanoproprioceptive loss would be. So that's eventually where we're going with each of these. So that's the anterior spinal artery. On the back side, as I said, there's a right and a left posterior that runs up and down this thing, and it's basically supplying those posterior columns and a little bit in between as far as the watershed area of these ventral horn or dorsal horn. Sneaking back to our pica discussion, we talked about pica lateral medullary syndrome, and we talked about how it sneaks around the medulla and eventually goes back. It's that cerebellum, and you get cerebellar signs, you get all the medullary stuff we talked about. But interesting enough, too, up top, that posterior spinal artery on each side originates off this pica. So again, you can kind of see how one artery can have some widespread effects, whether it's cerebellar signs or whether it's posterior column signs in the upper part of the spinal cord as far as damage goes. So again, just kind of make note that these things sneak out off of that pica or posterior inferior cerebellar artery. I didn't point it out either, too. The anterior spinal artery sneaks off of each of the right and left vertebral arteries. So again, remember we talked about the vertebral arteries and the dissection and VBI. you also have risks that can be a little more widespread of that upper C-spine that might be affected by some kind of infarct with the vertebral artery. So everybody's connected to everybody as far as the plumbing goes up there. Is the moral of the story. This was just a nice visual, though, to show you those posterior columns that are supplied by that. That's all. So again, I think I've given you plenty of visuals to entertain yourselves. This section here, I'm not sure. I don't have the outline in front of you. Did I remotely put anything about radicular artery and medullary artery? Okay, that's good. So we'll leave it at that. My intent with these couple of slides, bless you, was only to point out how there's some inconsistencies with it. In other words, as that descending aorta drops down your thoracic cavity, it's sending out branches all along the way that are eventually making their way back to the spinal cord, segmental branches. Some of those guys sneak around at each level, and they only plug into the local stuff, the nerve root at that level, and that's the radicular artery level of it. But meanwhile, some of them sneak out, plug into the local stuff, but then go in and plug in, bless you, into that anterior spinal artery. And these guys only happen every, say, 3, 4, 5 segments, and that's what I mean by the inconsistency. But that's how the spinal cord, is kind of supplied at each level. So even if you squish off the very top of the vertebral arteries, as we talked about, or blow out the very top, the rest of the cord does have other mechanisms of getting blood to it. And that was my only intent of these couple of slides, to highlight that concept. But it's not in your outline, and I'm not going to chase you on, the medullary or radicular arteries at each level or anything like that. So again, moral of the story is be able to identify if you have a posterior spinal artery problem and you lose that posterior part of the cord, you should understand what function is lost, and then the same thing as far as an anterior spinal, loss or infarct. So we'll sneak out of that. That's ended our discussion as far as blood supply. Now on to the cross-section. I'm going to not skip through this a little bit, but I think I only really want to highlight the makeup from enjoy the perspective of it, but not really the dirty details of it. Should appreciate this H-like thing in gray matter. Again, this is the unmyelinated cell bodies that are landed at each level, but they're arranged in a certain pattern on each side. They're arranged in multi-layers, these rexid layers, but in general, all of the sensory comes in the posterior horn, and it lands either first layer, second layer, third layer, depending what kind of the sensory input, it has its own little specific spot it lands in. Then to complicate matters or make this computer mechanism that more complicated is this layer may talk to this layer, which may talk to that layer, and have different little influences, so to speak. And then to add to the picture, you look at this thing vertically, and there's connections between this layer at, say, C5 and C6 and C7. In other words, there's kind of a local connection to the guys above and below, 1 or 2 segments. So the moral of the story is it's simplistic to think of a single, axon coming in and having a single connection up to this cortex. But there's plenty of interconnections down here, which means there's plenty of room for modulation and influence that goes on. So that's the extent of the discussion as far as the gray matter. Once you get up to the anterior horn, this is all motor output, as we said, and it is really the final pathway. In other words, everybody is talking to this. All the descending tracks, these guys are all talking to it. Different reflex information's talking to it. The other side is talking to it. But eventually, the motor output either is kind of like NASA, go or no go. Finally there's a on switch or not, and it's a sum total of all the information bombarding this anterior horn that determines, contract my bicep or do whatever you're going to do. So that's kind of a simplistic overview of these next 4 slides talking about the different layers. So I will repeat You do not have to memorize individual Rexid layers. Only thing I would like you to do as far as those layers is just break them up into a little bit of clumps. And the first 1 through 6 are all of that sensory information I had just chatted about on the dorsal horn. So as you look at this, you should just kind of, this should say dorsal horn. I've got an anterior there. All of that should land there, comes in, and it's lamina 1 through 6. But we do not have to, they each have names, and you get into the neuroscience of it all, and there's a whole circuitry in there that gets discussed. Meanwhile, up front, for the most part, 8 and 9 comprise that exiting motor output of the anterior horn for damage there. That terminology, final common pathway, is really describing what I was telling about. Everybody talks to these guys, but eventually they decide, go, no go, send action potential or not an action potential. They can't kind of send an action potential. They either do or they don't. So it's a sum total of inhibition and excitatory stimuli. All right, and then in the middle, there is this a layer in different spots that'll kind of out-pocket, but the autonomics tend to be in this area. So you've got all your somatosensory and information coming in, but in this region, there is that area. Don't forget, sympathetic tracts are coming down, talking and sneaking out, doing their thing along the thoracic spine. And there's parasympathetic information that eventually is getting down to the parasympathetics and the sacral plexus along the way too. So there is autonomic pathways, and they're making their way through kind of this lamina 7, if you will. And then last but not least, area 10 is the crisscrossing, very thin spot of connection between right and left that is known as quote-unquote the commissure. So that's the extent of it. 1 through 6 sensory, 8 and 9 motor, 7's the autonomics, and 10 is kind of that connection in the middle. When you look at this thing, the white matter, this is where we're looking at the tracks. So we'll be looking at the tracks here in this dorsal column, tracks in the lateral column, and tracks in the anterior column. And fairly easy if we kind of functionally look at them as we go for each of them. So again, I think the next few slides are highlighting a lot of what we had chatted about, maybe not. So the tracks. Descending tracks, I'm guessing we're going to start with first, we're going to look at motor output. And there'll be 2 layers of, or 2 functional descending tracks that we're going to look at. So there'll be motor tracks that are coming down on the outside or the lateral part of the spinal cord, and motor tracks coming along the anterior or medial part of the spinal cord. That's kind of the breakup between the 2 motor tracks. Keep in mind, as I said, autonomics are making their way up and down too, so yeah, they're still involved. And MLF, you go, okay, didn't we say that was a brainstem thing? And we talked about the function of that MLF being coordinating eyes, tracking, and all that stuff. But to track things and to coordinate, conjugate gaze, you got to turn your neck and, move the head. So the MLF does sneak down into the cervical spine. That's all. So, technically it's a tract part of the spinal cord. So let's hopefully get to our tracks. Oh, I guess I'm not. It looks like I just was introducing descending versus ascending. So ascending, 3 general areas we'll look at. Back column, which is all the proprio stuff. There's some way on the outside that is going to be your subconscious proprio stuff. And then there's some stuff in the front, anterior, lateral. That's all your pain and temp. So when you go back to study it, if you can kind of break it down into those 3 groups, I think it'll serve you well. So that was the intention of, these first 2 slides of descending tracks, ascending tracks, is don't get caught up in the weeds just yet. Just look at, what's going on here. There's some motor pathways on the side, motor pathways on the front. And then as far as things going back up, things in the back, things on the anterior or lateral part of things, and then some things way on the lateral part of things. So 3 basic subcategories when you look at all this. So again, plenty of entertainment as far as visuals. We'll be talking about these tracks. Appreciate that they are arranged similar to your cortex. There's a little, up here it's a homunculus, down here it's a somatotopic arrangement, cervical, and then all the way down to sacral. I'm not going to get too big into breaking that up, but again, appreciate it exists and why you would see some differences as far as different levels of the cord. So, that's about the extent of what I wanted to chat about there. Last but not least, there are some connections across here, especially your pain and temp pathways that land in here, cut over, and then start to go up the cord. So again, something like a central cord that's damaging this stuff is going to have some influence as far as pain and sensory loss, etc. All right, like to sneak on. Okay, finally we get to the tracks, and this is what I was referring to. So what I'd like to do is go over each of these in a pretty simplistic way, and I'm again going to highlight the big three that you have to be able to draw the pathway for, if you will. But in general, if you know where a track starts and where it finishes, usually you can put two and two together as far as function. And in a funny way, it's kind of like ligaments, the name, how the two bones name the ligament. Usually the tracks are named where it starts for the most part, especially with the motor tracks. So usually the name is helping you out. So we're going to look at the descending tracks first. And as I said, take-home message, two groups you need to memorize. This lateral group and this anterior or anterior medial group. The lateral group consists of lateral corticospinal tract, rubrospinal tract. They should ring a bell from some of our discussion as far as cerebellum. Lateral corticospinal tract, put a little star next to it and say, need to know pathway. Basically, I'll be asking you the question, if it gets dinged above the brainstem or below, is it contralateral loss, ipsilateral loss? So it's that simple. Rubrospinal tract, just going to have to know function. Don't worry about the pathway too much. All of these guys don't have to worry about pathway. So we're just looking at these guys functionally. So each one's going to get its slide. There'll be a discussion about which way they go and all that. But just kind of get your brain focused just on the functional piece of it. All right. So first one on the list, lateral corticospinal tract. Function-wise, fine motor movement, control, blah, 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 skilled movement, learned movement, discrete movement, all the things we do with our distal extremities to make us uniquely human, higher order beings, if you will. Play the piano, flute, whatever the physical skill is that we have. That is all through majority of it, the lateral corticospinal tract. So function-wise, pretty straightforward. Meanwhile, its cousin, this rubrospinal tract, is actually acting as a support proximal piece to all of that, and we'll get to it in a second. But that's the big picture of these tracks out here. So lateral corticospinal tract function, pretty straightforward. Pathway, motor cortex, primary motor that we had chatted about, shoots down through that internal capsule that we chatted about, makes its way down the front of the brainstem that we had chatted about, all three levels, gets to the medulla, and crosses. So that's where we left our story off. The nice thing is, not too much more to add to the story. So it started on the right side, got to the bottom of the medulla, crossed to the left side, and it's just going to make its way down the spinal cord in this lateral, column of the spinal cord. So that's, fairly straightforward. That's the extent of it. So the clinical differentiation is really where the lesion is. And so basically, wherever it crisscrosses tells you if it's going to be contralateral, ipsilateral. So it's above, it's going to be contralateral. If it's below, it's going to be ipsilateral as far as motor, hemiplegia or motor loss. So this visual helped you out. There's the cortex, internal capsule, brainstem, making its way and eventually crossing over at the bottom of the medulla and making its way down the outside of that spinal cord. Plugs into each of the motor levels, appropriate for the spinal cord. So the stroke here, the tumor there, the ding, any of the problems, as long as it's above the medulla, is going to give you contralateral hemiparesis, as you memorized so far for the cortex stuff, et cetera. Anything below it, oops, there we go, is going to be ipsilateral. Anything plugged in down below that lesion is going to be lost. Anything that plugs in above it will still function. So if I have damage at T12, well, all my cervical lateral cortical spine stuff is just fine. You know, I have motor function, my extremities are working. So that's the extent of knowing the pathway. So lateral cortical spinal tract, guarantee you be giving you a question, someone has damage, they lose half of the spinal cord or a certain segment, and you just have to put 2 and 2 together of what the motor loss would be from this tract. All right, and as usual, 20 pictures. Not 20, but all right, rubrospinal tract, red nucleus. Rubro, red, that's what it's referring to. We've had our discussion. Paravermis comes out, talks to that red nucleus. Remember, we had talked about that cerebellar. And this red nucleus, its job and what it does, it runs along with the lateral corticospinal tract, so it's fairly consistent with it. Paravermis, remember, it was responsible for the coordination of that distal extremity and fine movement and blah, blah, blah. But it was the real-time feedback, so the cerebellum is helping coordinating that distal, fine movement, whatever it is. So that's what the rubrospinal tract is, a continuation of that for simplistic definition function-wise. Then the other piece is this whole issue of muscle tone bias. Some of these tracts promote extension, some promote flexion. Rubrospinal tract promotes flexion, a flexor bias, if you will. So for each of these tracts, you have to kind of know which side of the coin they follow. So when we had our discussion before about the corticate and decerebrate, that's where that's coming from as far as whether you wind up in a decorticate or a decerebrate. But as I said, that's really too simplistic because it's way too rare that you have an isolated red nucleus problem or rubrospinal tract problem. Meanwhile, pathway, I don't know if this is all in your notes, but the good news is you do not have to memorize it the way you do the lateral corticospinal tract. But the only thing you should know is a majority of it lands in your upper half of the cord. And it makes sense. A lot of our fine motor control is upper extremity stuff in our fingers, and our feet don't, quote unquote, catch up with that so much. So a majority of it, terminates in the top half of the cord. It does exist further down, and there is coordination, but just not as prominent, that's all. But I will not ask you where it crosses over in the whole issue of ipsilateral or contralateral. The real question would be what the impact is on flexor tone, if you will. So theoretically, as we said, if there's damage above that red nucleus in the tract is always promoting flexor tone. Everything above it is acting as an inhibitor. So if you damage above, it allows this rubrospinal tract to have lots of flexor tone, and it would be helping promote that decorticate type, posturing, if you will. The opposite, if you knock out the tract, then you're going to obviously not have that flexor tone, and it'll be contributing towards that decerebrate type posturing. And again, I say that with very simplistic caveat, if you will. All right, so that's the lateral tracts, nice and easy. It's really that fine motor control of those distal limbs. Then you sneak over to these guys. This whole area is just responsible for the central stuff. Remember the cerebellum? You get to the vermis and the central portion of it, and a lot of it is discussion about proximal trunk control. Same thing here. So the moral of the story is all of these guys in this area, anterior medial motor tracts, are in line with postural control, depending on what they are. And then each of them have little maybe sub-specific roles, and that's about the extent of it. I will not ask you as far as, tracks, contralateral, ipsilateral, just look at it as if there's loss, there's going to be loss as far as that function goes. So let's look at these fairly simplistically. Tectospinal tract, tecto referring to tectum, tectum of midbrain, two colliculi, auditory for inferior, eyeballs for superior. What are they doing? All that innate reflexive stuff. So this tract is nothing more than the output of that stuff. In other words, I need to have a startle reflex, turn my head to auditory things, or a visual reflex. So this is the motor piece of that. That's all it is. So tectospinal tract, coordinating, blah, blah, blah. When you read through all of that, that's essentially what it's saying. And so it's the motor piece of it, and it's mostly the C-spine, because again, that's what's dictating motor output for these visual and auditory type reflexes, if you will. This whole flexor bias extensor thing, non-issue with tectospinal tract, doesn't play any role in that. So that's the simplistic nature. That's all you need to quote unquote know as far as tectospinal tract. Pay no attention to the pathway other than it's just found in the upper spine, in the cervical spine. And that's the star take-home message there. Next guy in line, anterior medial corticospinal tract. Didn't chat about it, but the stuff that comes out of your motor cortex, internal capsule, crosses over at the medulla, that's about 85%. 15% of it stays on the same side, and it makes up this thing called this anterior medial corticospinal tract. And really the take-home message is just think of it as proximal trunk control. That's simplistic. So we aren't going too far. Again, put a little star here. So far, no flexor extensor bias, so you don't have to add that to it. So really it's just rubro, and it's going to be reticulo and vestibular that are the biases, whether they're flexor or extensor. Pathway, same thing. Don't pay attention. I know the notes talk about ipsilateral crossing. I will not chase you on that distinction between them. So that's function-wise of that guy. Reticulospinal tract, there's two of them. And remember in our little brainstem lecture, we started, discussing the ones that come out of the pontine and the ones that come out of the medullary region. And this is that continuation of what we were referring to overall. So again, you look at this and go, have a role in modulating sensory pain input from spinal thalamic tract. Remember we talked about the reticular system and descending part of that reticular system. Pain comes in, goes up to the thalamus, gets up to cortex. Some of it's dropping off from reticular system and making a U-turn and going back down. And this is part of that pathway to land back down and modulate pain at the spinal cord level a little bit, and some other ways too. But motor-wise also has a role. In the simplistic version, again, this trunk proximal limb control is the generic answer. The only difference is medial versus lateral as far as extensor or flexor bias, and that's the only piece in all this. The reticular spinal tract, part of it goes down the outside near that lateral corticospinal and rubrospinal tracts. And then part of it runs down the front with these anterior guys. Rubrospinal tract is a flexor bias. We kind of beat that to a pulp. Well, it makes sense. The lateral reticulospinal tract that kind of runs along near it, also flexor bias. So moral of the story is this stuff in general has a flexor bias. This stuff is going to have an extensor bias. So vestibular, the one reticular that runs down there, tend to have the extensor bias as far as their core control, if you will. So that's what these next two slides are. Again, pay no attention to the pathways. I'm not breaking down that into ipsilateral, contralateral with this. Just want you to know it's got an extensor bias to it when we're talking about the medial, anterior medial portion of it. And if you think about it, protective mechanisms, when you fall, it's an extension motion. All our anti-gravity things are extensor type reactions. We don't, withdraw into flexor type patterns. So it sort of makes sense too as well. So anti-gravity postural muscle control, functionally it should make sense as to the hows and whys of it. So that's the extent of, looking at this. I'll sneak over to this one before we talk about the other. As I said before, this is a little bit more on the outside, running with that rubrospinal tract, and again, more in line with the flexor piece of it all. So that's how I would separate the two of them between each. So essentially, these two slides about a lesion above, below the red nucleus are a little too simplistic, and really the discussion should just be that I will ask you in terms of rubrospinal tract, but these guys really, you should just know if there's damage to it and it can't function, you have a loss of extensor tone, and same thing with this guy. If there's damage to it, there's loss of flexor tone. So I'll leave it at that. Do not worry about ipsilateral, bilateral, any of that along the discussion. All right, so moving on to vestibulospinal tract. It doesn't take rocket science to figure out its function. Again, vestibular, we talked about the whole issue of keeping our equilibrium and so on and so forth. So the moral of the story is there's two tracts that come down, but both of them are extensor tone. They're both running in this region. So the lateral is a little bit more lateral this way, but for the most part, they are up in the front of the cord. They aren't way out here with these guys. So the take-home message is both of them extensor bias. There's two different ones, but function-wise, again, postural, head-neck control, and trunk control, if you will. So, pretty simplistic discussion. You can easily see why all of these guys are really that core postural trunk control and tone control of extensors. Tectospinal, specific, again, to the C-spine and eyes, et cetera. Then the other ones to the whole body a little bit more so. All right. So that's summary of the tracts. As I said, know the lateral corticospinal tract pathway. All of the other descending ones, just look at them functionally, and if it's wiped out, what the influence might be, but know what their function is. That's all. All right, we do have to sneak over to the other side. I'm looking at the clock. I'll try to squeeze in what I can here. I'd like to at least get in, I guess I lied, so we aren't going to make it, and we aren't hitting the end of our black hole. We tried. Sensory tracts going upstairs, 3 of them. There's the back column, as we said, proprioception, discriminating touch, vibration. Physical exam, you do some form of balance, you do some form of finger to nose, heel to shin type testing, discriminating touch, 2-point discriminator, tuning fork. There's your physical exam to assess the function of those posterior columns. Subconscious proprioception, this is all quote-unquote conscious. This is stuff, you're kind of aware of. But you don't realize in that real time, when you're doing it, the feedback that's going on and saying, hey, is it what I want, and the adjustments that go on. And remember, we talked about in the cerebellum as far as the paravermis doing that, and those guys, the spinocerebellum tracts getting into it, and they go up and over, and the big discrepancy. Do they go in the top one or the bottom one? They get in there eventually, and their real role is to make real-time corrections. So when you see the term subconscious, that's what's going on. You don't give it a thought, but that's how you continue to execute whatever your skilled voluntary movement is. So that's the second region that this goes on. And then last but not least is this anterior lateral spinal thalamic pathway. And there's a cluster of nuclei, but they're all related to conveying pain. The only difference is some convey very specific pain, ouch, that's my thumb. Some convey the information to the reticular tract or the more diffuse areas of the brain to give you the emotional response of, I got pain going on. So that's a simplistic breakdown of the ascending. The 2 tracts you will need to know is this posterior column, dorsal column, medial lemniscus pathway, and then the lateral spinal thalamic tract. So that's, the ghost of what's coming as far as each of these. So I will try to knock off the dorsal column here, squeezing this in before the dinner bell. Proprioception goes through this system, and it goes through it in kind of a three-tiered system. Way back when, all of the sensory tracts tend to have a first-order neuron connection, a second neuron connection, and that's usually the one that's going up, but not always, or the one that lands in the thalamus. And then the third order is usually the thalamus to the cortex connection. And again, it depends on some of the sub-level ones. But for each of these, or for the lateral spinal thalamic and for the dorsal column, you will need to know the pathway of those. So that's what the intent is of these slides. So dorsal column, I've got GTO, I've got all my mechanoreceptors, from my extremities need to get this stuff upstairs to cerebellum and also upstairs to motor cortex 312 to, figure out what's going on. So that input comes in and it lands in that dorsal horn as we talked about, and then it sneaks over. I should back up. It just comes in, lands over, and it just goes straight up the back. So let me get our mechanoreceptor here. So it's coming in the dorsal column, or dorsal horn, sneaks into the dorsal column, and it goes all the way upstairs to our good friend, the medulla, the bottom of the medulla, and it junctions. And that's the end of this first order neuron. So there's connection number one. What's it going to do in the medulla? Cross over. So again, this medulla is the action site for everything crisscrossing. So the second order crisscrosses over, makes its way up. Who's this guy? That medial lemniscus thing we talked about. Remember, the lemniscus is nothing more than that conduit for all these guys' sensory getting upstairs. So this is that medial lemniscus portion that says, proprioception from the body. This is how the brainstem piece of it goes. Goes all the way upstairs to thalamus, lands in the thalamus, and then it's going to project specifically to specific areas of 312, my thumb, my foot, whatever homunculus spot my cortex it represents. So that's the pathway. The real key is damage here is going to be ipsilateral loss. Damage above that medulla, contralateral loss. So again, just put two and two together, be able to draw it, and then recognize the ding that may go on. The only final discussion, if I can find it here with this dorsal column, is inside these columns, you have the fasciculus cuneate, gracillae. These guys are a little bit more medial as far as the gracillae. In other words, down in the lumbar thoracic region, there is no cuneate. In other words, the information comes in from the feet and the lower extremities, goes up the back, but then you get up to cervical, and it comes in from the arms, and the arm stuff lands here in this thing called the cuneate. So by definition, this thing is really located above, your thoracic region, obviously. It just doesn't make sense that it would exist. But these two packets of information eventually get to medulla, sneak over to medial lemniscus, thalamus, and to the 312 area as far as pathway. All right. It's way too late here. I'm looking at the clock. I've killed my over the time there. So we will sneak it in Wednesday. It will fit. The other chords, not quite as much to talk about, but as I said, so far, lateral corticospinal, dorsal column are the two tracks. You got to draw the pathway. So my apologies for keeping you late here. Worcester, you guys have a good weekend. Manchester, you do.